السلام عليكم ورحمة الله. Hello everybody. We'll start, we'll continue our ACLS coursework, and this is lesson 9 اللي هو stroke part 1. طيب let's start.
Or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Stroke is a leading cause of death and the #1 cause of disability among adults in the United States. We're going to demonstrate how to quickly recognize the telltale symptoms of acute ischemic stroke and model how to respond promptly and with appropriate care and treatment. First, let's review the pathophysiology. A stroke occurs when blood flow to the brain is interrupted, either by a clot, called an ischemic stroke, or when a blood vessel ruptures, called a hemorrhagic stroke. 87% of all strokes in the United States are ischemic. This type of stroke occurs when plaque due to atherosclerosis collects along the walls of the arteries, narrowing the arteries leading to or lying within the brain. As in the coronary arteries, disruption of the vessel wall can cause a clot to form, further narrowing or even occluding the artery. Pieces of clot can break off and travel deeper into the arteries and eventually lodge in a smaller vessel in the brain and cause a stroke there. This interruption in blood flow ceases function in the affected brain tissue, leading to a sudden onset of symptoms. Brain injury can be minimized and fatalities can be avoided when family members and healthcare providers use the stroke algorithm and follow both the stroke chain of survival and the 8 Ds of stroke care. When a stroke occurs, the stroke chain of survival suggests the following actions: rapid recognition and reaction to stroke warning signs, rapid EMS dispatch, rapid EMS system transport and pre-arrival notification to the receiving hospital, and rapid diagnosis and treatment in the hospital. The 8 Ds of stroke care act in coordination with the chain of survival. As our case study reveals, it's essential that family and healthcare providers follow these steps and work together to rapidly recognize and treat acute ischemic stroke. As you'll see, time is brain. Because many strokes occur at home, it's essential that family members recognize the signs of a stroke and promptly call for help.
It all happened so quickly. 1 minute she was fine, and then the next minute she just fell over. Ellie, honey, what's wrong? Talk to me. It's okay. I'm gonna call 911. Something's wrong. Her mouth was drooping. She couldn't speak. The whole right side of her body just went limp. Immediately I called 911.
As you can see, the first crucial step in the stroke chain of survival is activating the emergency response system. This is also the first D in the 8 Ds of stroke care: detection of symptoms.
طيب هنواصل طوالي. اتكلم عن الستروك chain of survival، وانه عندنا اول حاجه الاكتيفيشن اوف emergency system، انه انت تو ديتكت او انه في حاجه ابنورمال وتقوم تتصل بالاسعاف. دي اول خطوه. كويس. وهيتكلم طبعا في النكست فيديو عن كيف تتعرف على الاستروك، الكويك اسسمنت للاستروك وكده. طيب هنشوف لو في كويستشن نحلها ونمشي طوالي في نفس الفيديو. طيب قال what is the major signs of patient having stroke؟ facial drooping. كويس. طبعا لا سيانوزيس لا سويتن، الوش يحصل له ماوس ديفيجن او يكون في جزء واقع. دي واحد من الستروك. طيب نمشي نشوف اللي بعديها. what are the major type of stroke؟ طبعا ischemic and hemorrhagic. دي straight forward questions. نمشي. قال what is the most common type of stroke؟ طبعا الاسكيميك قال نسبتها في يونايتد ستيتس 87%، وهي اصلا في كل العالم نسبتها ما بتقل من 85% والهيموريجيك بتكون 15%. اسكيميك ستروك. طيب نمشي طوالي ونشوف بارت 2 ونشغل ونشوف اللي بيحصل شنو.
Rescue 21 respond. 3326 Davis Lane, possible CBA.
Rescue 21, copy.
Activation of
You're responding
emergency.
to a 45-year-old female with notable weakness to the right side and facial droop.
The second link in the stroke chain of survival is rapid EMS dispatch. This is also the second D in the 8 Ds of stroke care.
Yellow detection.
Strokes receive a high dispatch priority, and we try to get there as quickly as possible. Part of the reason to get to them quickly is in case there's a life-threatening problem, but another part is to get them to a stroke hospital where fibrinolytic treatment can be administered and possibly reverse the damage.
They're here.
Hi, Mrs. Vega. We're going to help you out. Eddie's going to take your vitals, and I'm going to ask a few questions. Well, the first thing I want to do is rule out any other possible causes for the patient's condition. I discovered Mrs. Vega wasn't experiencing any chest or back pain, and she wasn't having any trouble breathing. Mr. Vega also informed us that she didn't have any history of diabetes or seizures. And to rule out hypoglycemia, we did a quick finger stick blood glucose analysis. It was fine. I also confirmed she's on any blood thinners.
EMS should also test the neurologic condition of the patient with a stroke assessment, such as the Cincinnati Pre-Hospital Stroke Scale.
Mrs. Vega, can you smile for me? Okay, Mrs. Vega. Try to close your eyes. I want you to hold your hands out front. Okay. Mrs. Vega, I want you to repeat something for me. Can you say, "You can't teach an old dog new tricks"? You can't teach dog. The stroke test definitely showed key abnormal indicators, strong signs of a possible stroke. And Mr. Vega informed us that the symptoms had started 20 minutes before we arrived. I know I had to make decisions quickly.
To help identify which hospital is most appropriate for the stroke patient, EMS should also perform a severity screen to indicate if there is a possible large vessel occlusion. As always, EMS should follow local stroke protocols.
What are her vitals?
Blood pressure is 190 over 110, heart rate's 110, respirations are at 14, her pulse ox is 95.
Her blood pressure was elevated, but her oxygen saturation was normal. Mr. Vega, we think your wife is having a stroke. We'll need you to come with us to County Medical. They're specially equipped to handle the situation. The sooner we get there, the better.
Good. Happened so fast. The EMS team had her checked out in 10 minutes. And they even let me ride in the back. Keep her calm and answer any questions.
The third link in the stroke chain of survival is rapid EMS transport to a hospital that is equipped to deal with acute stroke. This is also the third D of the 8 Ds of stroke care, delivery of the patient by rapid EMS transport.
Rescue 21, go ahead. We are en route with a possible stroke patient, a 45-year-old female with weakness on right side, facial droop on right side, and difficulty speaking. While we were en route to the stroke center, I radioed ahead so that the stroke team could be fully prepared once we arrived. Patient's blood pressure is 190 over 110. Her heart rate is 110, and her respiratory rate is 14 without difficulty breathing. Patient's blood glucose level and pulse oximetry readings are within normal limits. The patient's ECG shows sinus tachycardia without ectopy, and according to family members, the first onset of symptoms was approximately 23 minutes ago, 11 a.m., and we have an estimated time of arrival of 5 minutes.
Received Rescue 21. We'll be ready. Let's activate our stroke team.
طيب في الفيديو ده اتكلموا عن الديتكشن والديسباتش والديليفري. ديتكشن انه الشخص يعمل ديتكشن للاعراض سيمبتومز اكوردنج للسنسناتي كويك هنا اللي هو انه بتقول العيان ابتسم تشوف هل في فيشل دروبين اللي هو فيشل ماوس ديفيجن وبتخليه ينطق تقول له قول جمله هتلقى انه في ابنورمال سبيتش تقول له ارفع يدينك الاثنين في يد، حيكون في سايد ويكنس اللي هو بسموه ارم دريفت. كويس. سنسناتي كويك ستروك اسسمنت. الثلاثه حاجات دي ممكن اي زول هنا خلاص ضرب وعرفوا وشالوا العيان. فهي ديتكشن في الاول، شخص الضرب حسينا فيه ابنورماليتي، جت تيم اللي هو ديسباتش وصل، بعد ذاك الدليفري انه يسوقوه انه له دليفري للمستشفى، بعد ذاك طبعا الدور ونمشي نشوف باقي الحاجات. طيب حنشوف الكويستشنز ونشوف الستروك لانه الستروك هنا. طيب قال what stroke screening was used in stroke in the video. السنسناتي اللي هو اختصاره اعتقد ده سنسناتي كده ستروك اسسمنت صح؟ يس. طيب which is a signs or symptoms of stroke. trouble speaking, nausea, shortness of breath. لا طبعا trouble speaking. طيب why it is important for emergency medical service personnel to alert the receiving facility stroke team as soon as possible. ليه الناس الإسعاف مفروض يوروا المستشفى اللي هم ماشيين والله ده يعني يكلموا انه لازم يعملوا اكتيفيشن للستروك تيم، الستروك تيم يكون جاهز، لانه طبعا في سباق مع الزمن. احنا نشوف الاسئله. ده الهوسبيتال كان determine eligibility for fibrinolytic therapy, reduce time interval to definitive care. Stroke team can provide early medical direction to EM crew, receiving instruction on appropriate destination. انا اعتقد انه eligibility for fibrinolytic therapy طبعا في الاخير في اسئله هنا صحيحه. reduce the time interval to definitive care. يس انت لما تضرب من بدري بتقلل الزمن اللي لحد ما العيان يلقى العلاج الاساسي. لكن الاولويه في شنو؟ الاولويه انه تداير يجهزوا لك الفيبروليتيك سيستم حادثه الاعتقادي. طيب ستروك تيم كان بروفايد ايرلي ميديكال دايركشن تو EMS برضه صحيحه، وريسيفنج انستراكشن او ابروبريت ديستنيشن برضه صحيحه. يعني برضه هم ممكن يضربوا للمستشفى، المستشفى يقوم يديهم تعليمات انه والله امشوا الحته الفلانيه ما تجوا الحته دي كلها صحيحه. لكن الاولويه انا اعتقد انه عشان يجهزوا الفيبروليتيك لانه دي طلعت رم الستروك provide early medical direction to EM crew, reduce time definitive care. كلها صحيحة. نحن نشوف تراي غالبا دي أو دي، لكن نحن ترايته راندم دي ونشوف دي. أوكي reduce لأن هي كلها صحيحة. reduce the time to definitive care. اللي هو definitive care ممكن يكون الفيبرونيتيك، فهم هنا الأسئلة كلها بتتشابه، فكلها هي صحيحة. لكن according لهم هم بيروا إنه عشان كده واي انك انت لازم تشتغل بنظامه. هم بيروا انه الاختصار للجمله دي انه reduce time to definitive care. الديفينيتيف كير ممكن يكون في برونيتيك، انه حتبدا له في برونيتيك سيستم كويس. ايفن تعمل له حاجه اسمها امبولوكتومي، مرات بدخلوا سريع ناس النيوروسيرجن يقوموا يشيلوا الجلطه كويس. فهي المهم انه الديفينيتيف كير. اوكي طيب نشوف الستروك بارت 3 سريع.
There is a limited window of opportunity to evaluate the patient, determine eligibility for fibrinolytics, and start the drugs. Getting that advance notice from EMS allows me to notify the stroke team so that they're poised to respond when that patient arrives.
The fourth D of stroke care.
There is a limited window of opportunity to
فقلنا
evaluate the patient,
الويندو is very
determine
important.
eligibility for fibrinolytics, and start the drugs. Getting that advance notice from EMS allows me to notify the stroke team so that they're poised to respond when that patient arrives.
The fourth D of stroke care is DOOR. DOOR stands for the effective triage of the patient. The initial evaluation should include assessment of the patient's ABCs, airway, breathing, and circulation. Hospital personnel should administer oxygen if the patient becomes hypoxemic while en route. It is best practice to bypass the ED and take the patient straight to the CT or MRI suite. Hospital personnel should assess a patient with a suspected stroke within 10 minutes after the patient's arrival in the ED, CT suite, or MRI suite. Follow your local protocol. Confirm IV patency and draw blood samples for blood glucose, electrolyte, CBC, and coagulation studies. Even though EMS did a fingerstick blood glucose analysis, hospital personnel should review and verify blood glucose results. Hospital personnel should also acquire a 12-lead ECG, which may identify a recent myocardial infarction or arrhythmia as a potential cause of the stroke. The next step in the 8 Ds of stroke care involves the collection of data, ideally within the first 20 minutes of a suspected stroke patient's arrival.
I get her history, perform a general physical examination, a neurologic examination, and establish the time of symptom onset. In this case, the first symptoms were about 45 minutes before. After asking a few questions and performing the NIH stroke scale, there were pretty clear indicators of a stroke. Since EMS had called ahead on their way to us, we already had our neurologist standing by.
Now, you have to remember the clock is ticking, so that means that you must evaluate the scan immediately. Now, our benchmark is that should happen within 45 minutes of the patient's arrival. The CT scan will help me determine if an intracranial hemorrhage is present. Now, if a hemorrhage is present, then our stroke team is going to pursue an entirely different path of treatment. On the other hand, if I find a normal CT scan, as in this case, that suggests an acute ischemic stroke is causing the patient's symptoms.
That brings us to the final link in the stroke chain of survival: rapid diagnosis and treatment in a hospital equipped for acute stroke patients. This is also the 6th D in stroke care: decision regarding treatment. In addition to IV fibrinolytics, endovascular therapy is recommended for large vessel occlusion, or LVO, patients who meet inclusion and time criteria. In some cases, endovascular procedures may not be available. An interfacility transfer should take place for those that meet the criteria for endovascular therapy.
With an ischemic stroke, CT scans often look normal within the first few hours of symptom onset. In this case, the CT scan looked normal and there was no evidence of bleeding. Thankfully, we were well within the window of fibrinolytic therapy. But before I recommended that treatment, I performed another neurologic exam and I asked some questions that were part of the fibrinolytic checklist. The neurologic exam showed no improvement. But before recommending fibrinolytic therapy, I wanted to review the patient's records and to see if there was any pre-existing conditions that might interfere with the drug treatment. These include brain hemorrhage, prior stroke, abnormal blood vessels in the brain, recent bleeding anywhere, any history of blood clotting problems, recent surgery or accidents, or certain prescription medications. Now, I wasn't seeing any potential problems with the drug therapy. Nancy, what's her current BP?
It's 192/114.
Okay, your blood pressure's still a little bit high, so we're going to give you a drug to help bring that down, okay? Okay, let's give her 10 milligrams of labetalol and try to get her systolic blood pressure down to 185 and her diastolic down to 110. Now we'll recheck in about 3 to 5 minutes. If it's still elevated, then we need to double it or consider an IV infusion. Let's don't waste time here.
Okay, right away.
Okay, that's right.
If the patient's medical history is acceptable, if the time of onset is generally less than 3 hours, and if the patient's current condition can be managed within suitable parameters, it's time to move to the next D of stroke care: drug and/or device.
Mrs. Vega, we'd like to recommend a medication to you that may break up the blood clot that's causing the stroke. But we'd like to talk to you about the potential risks of this medication so you can make an informed decision.
What kind of risks?
There is a small possibility of having a cerebral hemorrhage that's bleeding into the brain. Now, if this occurs, Mrs. Vega's situation could get worse or may even possibly be fatal.
Well, it's only a very small risk, actually, about 5%.
That's right, but you still need to consider it. Now, the upside to this is the drug treatment may break up the blood clot in the brain, potentially restoring or improving blood flow to the affected areas, and that's a good thing.
Studies show that the drug therapy can improve the chances of recovery by 30% if administered within the first 3 hours of the symptom onset.
Now, the window can be extended for some select patients to 4.5 hours, but Mrs. Vega will easily make the 3-hour window, and that's even better.
That number works for me. Sounds like it's worth the risk. Honey?
Okay. Nancy, based on her weight, let's administer our TPA according to our protocol.
Will do.
Okay, it's going to take us about an hour to give this medication to you through your IV.
I would do blood pressure and neuro checks every 15 minutes while she's taking the therapy. I'd also monitor her neurologic status.
Good. Looks like you're in good hands. I'll check back with you after the therapy.
طيب في الستروك عندنا ال 8D detection dispatch delivery door data detection drug and device disposition. في الأول زي ما قلنا detection للأعراض جنس ال AMS حصل dispatch جو سريع. بعد ذاك ساقوا العيان ديليفري للهوسبيتال. في الوقت ده كانوا عملوا حاجات أثناء الديليفري. جو في الدور بتاع الهوسبيتال. يلا في الدور طوالي بتبدأ تجمع الداتا. بيقول لك الاسسمنت في الاي دي في الامرجنسي ديبارتمنت 10 دقائق فقط. عيان الاستروك الجاي بانه سسبكت ستروك ناس الاسعاف جايبينه انه عنده ستروك، عندك 10 دقائق في غرفه الحوادث تعمل لها اسسمنت. طوالي توديه السيتي سكان. السيتي سكان بعد ال10 دقائق عندك 20 دقيقه. السيتي سكان المفروض في خلال نص ساعه من البيشنت ارايفل، يعني بعد 20 دقيقه 20 دقيقه. طيب الاسسمنت بتاع السيتي سكان بعد 45 دقيقه من وصول العيان. يعني لو اتعملت السيتي بعد 20 دقيقه بعد 30 دقيقه الراديولوجيست او الطبيب المعالج عنده 15 دقيقه يغيم فيها السيتي سكان. بيتشال عينات لسي بي سي، بلاد جلوكوز، الكترولايت، كواجوليشن بروفايل، دي كلها لازم تتشال للعيان. وبعد ذلك ممكن الديسيشن بتاع انه ياخد فيبرونيتيك 3 ساعات من وصول العيان، ممكن تتمدى لحد 4 ساعات ونص. في اللحظه دي العيان ممكن يستفيد من شنو؟ من الفيبرونيتيك دروكس اللي هو الادويه حاله للجلطه. وبيعرفوا الاستفاده كيف؟ لانه بيعملوا كونتينيوس نيورولوجيكال اسسمنت. كل مره بيعملوا له شكل الباور لحاجات كل النيورولوجيكال كويس، الكرينيال نيرف، الفيشيال نيرف، الحاجات دي كلها. فاذا ماشي في تحسن بيكون واضح كويس. اللي هي بعد الداتا الفحوصات بيكون الديسيشن انه اتشخصت هي شنو بالضبط، هل هي اسكيميك ستروك ولا هيموريجيك. بعد ذاك طوالي بيبقى الدركس لو كان فيبرونيتيك يعني كانت اسكيميك طوالي حيبدو في الفيبرونيتيك. وبعد ذاك الديسبوزيشن اللي هو بعد ما العيان انتهى. فهنستمر طوالي في هنشوف الكويستشن وهنستمر في السيشن بتاعنا. Let us go to the question. What is the highest priority once the patient has reached the emergency department hospital? Lab, X-ray, ECG, CT scan. في الاستروك الهاي برايورتي طبعا السيتي سكان. الهاي برايورتي هي السيتي سكان، لانه ايفن قال تو سكيب يعني من ال EMS من الاسعاف يمشي طوالي للسيتي سكان. لكن اذا مر بالامرجنسي ديبارتمنت ما ياخذوا معاه اكثر من 10 دقائق. هي المفروض تكون السيتي سكان. رايت. طيب what the time goal for neurological assessment by stroke team or designing and non-contrast CT or MRI performs after hospital arrival. طيب what is the time goal for neurological assessment by the stroke team or designing and non-contrast CT or MRI performed after hospital arrival. المفروض after الاسسمنت 10 دقائق، وبعد 10 دقائق طوالي حيمشي يتعمل السيتي سكان. لو اخذت 20 دقيقة حتكون نص ساعة، المفروض تكون 10 دقائق المفروض. طيب معناها 20 دقيقة 10 دقائق اسسمنت. بعد ذاك السيتي تكون اتعملت يعني بعد 20 دقيقة من وصوله. 10 دقائق يتعمل اسسمنت، مجرد ما خش زيرو من 0 ل 10 دقائق يتعمل الاسسمنت. من بعد ال10 دقائق بيرسلوا للسي تي. في خلال بعد 20 دقيقة المفروض يخش السي تي، يتعمل السي تي في بعد 20 مينت. طيب الويندو قال ذا برايمري تايم ويندو فور ادمنستريشن اوف فيبروليتيك. طبعا هي لحد 4:30، لكن هو هنا خيار 4:30 ما مديك، هي اصلا 3 اورز. لو العيان جاك وزن 3 اور من بداية السيبتومز انت بتديه الفيبروليتيك سيستم او الفيبروليتيك دراكس. طيب نمشي لاخر بارت في خلصنا ده كله. كنا عندنا اخر بارت في الستروك اللي هو ستروك 4. ايفن ما عندها كويستشن شكله. بعد ذاك تمورو ان شاء الله نخش في الاريزميا، البراديكارديا والتاكيكارديا، نيجي لكاردياك ارست عشان نكون نهينا السيشن بتاعنا بالبوست كاردياك ارست كير. طيب نشوف السيشن الاخير.
After starting IV alteplase, the patient should be moved to the cath lab for endovascular therapy if they meet the criteria for large vessel occlusion. Patients who do not meet the time criteria for IV fibrinolytics may be candidates for endovascular therapy up to 24 hours after last known normal. For optimal recovery, hospital personnel must carefully control the patient's blood glucose levels, temperature, and blood pressure. The final D in the 8 Ds of stroke care is disposition. This means rapidly admitting the patient to a stroke unit or critical care unit.
She'll be surrounded by a team of people who specialize in stroke. Statistics show that these specialty units provide best practices and not only increase her chances of survival, but really improve her outcome as well. With a little physical therapy and time on her side, she's likely to have a full recovery.
By rapidly recognizing the signs of acute stroke and preventing delay in diagnosis and treatment, you give the patient considerably higher chances for a full recovery.
نتكلم عن انه ندي الاي في التريبتيز او الفيبرونيتيك دراج وزن البيريود زي ما قلنا هي 3 ساعات، لكن اب تو 4.5 ساعه 4.5 ساعه. عندنا برضو الاندوفاسكولار سيرابي اللي هو العيان بيدخلوه اذا كان في لارج بلود فيزلز اوكلوجن، لانه السيرمبوليتيك هتشتغل بطيء. اذا كانت بلود فيزلز كبير وجلطه بخشوا ناس النيروسيرجري مع ناس الكاس لاب، زي ما بخشوا للقسطره بخشوا في الارتري ده وبيسحبوا الجلطه. طيب ودي لحد وزن 24 ساعه from last normal. يعني شوف في فرق بين انه يقول لك from first medical contact. ركزوا في الحاجه دي، يعني يقول لك from first medical contact معناها لما انت اتصلت. دي في البروتوكولات مهمه. لما انت اتصلت والاسعاف جاء، اول ما الاسعاف جاء دايما يقول لك اوف فيرست ميديكال كونتاكت معناها زمن الاسعاف فيه جاء وريكوجنايز الحاله. لما يقول لك افتر 24 اور فروم لاست سين نورمال معناها العيان ده ممكن يكون نام امبارح، نام امس الساعه 8 كان طبيعي، صحى من النوم بس ترك صحى بعد 3 ساعات. انت هتحسب من اخر مره هو كان طبيعي، التلفزيون كان فيه شنو وات ايفر انت بتقدر في الاخير نام الساعه كده كان طبيعي، والله صحى كان ما قادر يقول. فانت بتشوف اخر مره كان سليم. الاندوفاسكولار سيرابي دي 24 ساعه from last seen normal from last seen normal. طيب بعد ده زي ما قلنا للاوبتيمال ريكفري الستروك تيم بيعمل لازم البلد جلوكوز يكون مينتين، التمبريتشر تكون مينتين، البلد بريشر يكون مينتين. This is about الستروك. نشوف الكويستشنز. Actually ما في question. فحيكون عندنا السيشن الجاي هو الاريزميا، بنبدا بالبراديكارديا. Thank you very much for your listening.